Welcome to the topic disseminated intravascular coagulation, what is commonly known as DIC. It is so called as nightmare for the treating physician. It is so called because it is a paradoxical disease or a syndrome. It's actually not a disease per se, it is a syndrome where sometimes patient will manifest with a thrombosis. If you treat for thrombosis, patient will immediately start bleeding. So episodes of thrombosis and bleeding will continue, and invariably this is a disease or a syndrome which will carry very high mortality rate. So that's why it is a nightmare for the treating physician. So let us have a look what are the causes for this DIC, how to identify, what are the laboratory investigation of DIC, and how to treat a DIC. So it is an acquired syndrome. Remember, DIC is never inherited, it is an acquired syndrome. It is not a disease, not a single disease. It is manifestation of underlying disease. It is characterized by systemic intravascular coagulation. Coagulation is always the initial event. So coagulation is the one which will start initially, and it carries very high morbidity and mortality because it carries an component of a thrombosis. So it all depends what is the extent of a thrombosis. If the extent of thrombosis, if it is more and more organs will show thrombosis, and they will show ischemic necrosis and ischemic damage and organ failure. What are the causes for DIC? There is no single cause for DIC. It could be due to the various underlying conditions. It could be manifestation of underlying leukemias like AML M3. Acute promyelocytic leukemia can manifest with the DIC. Metastatic disorders, especially the mucin secreting adenocarcinomas, can manifest with the DIC. Patient having cardiovascular disorders like post-cardiac arrest, acute myocardial infarction, or patient who has undergone implantation of prosthetic valve devices, they can manifest with the DIC. Both hypothermia and hyperthermia patients, they can manifest with the DIC. The lung disorders like acute respiratory distress syndrome, pulmonary embolism, severe acidosis, severe anoxia, various other collagen vascular disorders, and even anaphylaxis can manifest with the DIC. So there could be so many underlying disorders which will clinically manifest with the DIC. Most importantly, you have to remember it could be even manifestation of underlying infectious diseases or gram-negative septicemias, especially Neisseria and even meningococcal, they will manifest with the DIC. Sometimes even viral infections like CME, varicella, and even hepatitis can manifest with the DIC. Rarely fungal disorders. Acute liver disorders also can manifest with the DIC sometimes. Or it could be due to after the post-traumatic severe trauma, extensive surgeries, tissue necrosis, and extensive head trauma can all manifest with the DIC. Last but not the least is the obstetric complications can manifest with the DIC like amniotic fluid embolism, placental absorption, then eclampsia patients, especially eclampsia patients can manifest with the DIC, and missed abortion with the retention of fetal products in the uterus, they can also manifest with the DIC. So remember, DIC is manifestation of underlying disorders. Procoagulant is always takes plus, and it will be more in a patient with the DIC as compared to the anticoagulant. So this particular disturbance results in the onset of a DIC. So this is a pathogenesis of DIC. There will be always high procoagulant activity. There will be a systemic activation of coagulation cascade due to variety of underlying etiological factors that results in intravascular deposition of the fibrin and formation of a thrombus. This thrombus can affect either medium-sized vessels or even small-sized vessels. So various organs will show thrombosis and they will suffer from ischemic necrosis. So that finally results in the organ failure. In the process of formation of a thrombus, there will be a consumption of the platelets, right? So platelets will be consumed, there will be a depletion of the platelets, and even other coagulation factors will be consumed in the process of thrombus formation. So that results in bleeding. So initially it will be a thrombosis, later on it will be manifested with a bleeding. So both thrombosis resulting in organ failure as well as massive bleeding, both can result in a death. So high mortality is the the very common complication of the untreated DIC cases. As the platelets are consumed in this process, so it's also known as consumption coagulopathy. So DIC is also called as consumption coagulopathy. What is consumed? Platelets are consumed, coagulation factors are consumed. So how to diagnose DIC? To diagnose DIC, you have to suspect the presence of underlying disorders that are making the patient to manifest with the signs and symptoms of DIC. You have to look for the appropriate clinical settings, clinical evidence of thrombosis or hemorrhage, sometimes both will be there. So you have to do variety of laboratory tests to conclude that it is a case of DIC. Remember, there is no single test that is the accurate for DIC. You have to do plenty of tests to conclude that it is a case of DIC. A serial test are more important than the single test. You have to do repeated investigations. How the patient will manifest with a DIC? So patient can have both hemorrhagic manifestations as well as thrombotic manifestations. For example, in skin, because of ischemia, patient can have gangrene and acral sonesis, or because of hemorrhage, he can have petechial hemorrhages or sometimes oozing or even ecchymosis. CNS, central nervous system, patient can become delirious or he can undergo even coma. It is all because of the presence of infarctions. The cerebral vessels can get infarcted, and there will be a thrombosis and results in the seizures, and even coma can occur. There can be even severe intracranial hemorrhage can take place because platelets can be consumed in a huge quantity. A renal manifestation, patient can have oliguria, azotemia, and even cortical necrosis. If there is a hemorrhagic symptoms, patient will have a massive hematuria. So you have to examine his urine color. Serious manifestation, patient can have a myocardial dysfunction. Pulmonary manifestation, like patient can have a dyspnea, hypoxia, and sometimes even severe pulmonary infarctions. Sometimes even severe hemorrhage can take place within the lung parenchyma. GI manifestation, patient can have ulcers, infarctions, and sometimes massive GI hemorrhage can take place. Adrenal infarction, very classically seen with the Neisseria, septicemia cases. The adrenal infarction can result in a syndrome so called as Waterhouse-Friderichsen syndrome. That could be a manifestation of underlying DIC. When the physician sends a blood sample to pathologist, what the pathologist will see under microscopy is see the changes of DIC. There will be a fragmented RBCs. There are so called as cystocytes, and even there is a polychromatophilic cells. But what is very striking is no platelets. Almost platelets are not at all there. So severe thrombocytopenia will be there. Along with that, hemolytic anemia changes will be there. So fragmented RBCs, nucleated RBCs, polychromatophilic RBCs, and even sometimes microspherocytes all indicates that this is a changes, hemolytic anemia changes are there. So one should suspect a DIC in these setups. So if proper clinical history is given, pathologist will make a diagnosis that yes, it's a manifestation of DIC. Before making a diagnosis as DIC, you have to rule out the other underlying disorders which will also manifest with the bleeding, like severe liver failure, vitamin K deficiencies, and thrombocytopenic purpuras, various other congenital abnormalities of the fibrinogen. So many underlying disorders which will manifest with the bleeding, you have to rule out. Then only you can conclude that it could be a case of DIC. So no single test, laboratory test is the diagnostic for DIC. You have to do plenty of and a series of investigation, and you have to keep on repeating this investigation almost every day. D-dimer assay, what we call it as FDPs, fibrin degradation products, are elevated in patient with a DIC. Platelet count, invariably they will go down, so there will be a thrombocytopenia, sometimes severe thrombocytopenia. Thrombin time and prothrombin time, activated partial thromboplastin time, all will be elevated. Fibrinogen levels you have to do estimation, you have to do coagulation factor levels assay you have to do. So most of the tests you have to repeat once again, and to come to a conclusion that with the clinical conditions you have to correlate the laboratory findings, then only you can make a diagnosis of DIC. Otherwise, diagnosing DIC sometimes is really challenging for both physician as well as the pathologist. What is the treatment for DIC? You have to treat the underlying trigger. So you have to stop the underlying triggering process. That is the only proven treatment for DIC. DIC as such, it is not a disease. You cannot treat a DIC. You have to treat the underlying cause. For example, if it is a retention of products of conception that are manifesting with a DIC, you have to remove those products of conception from uterus. Then treat. DIC will totally disappear by itself. So treat the underlying disease, then DIC will disappear by itself. Along with that, you have to give a supportive therapies. There is no specific treatment for DIC as such. You have to consider the infusion of the platelets, and plasma therapy should be considered. You have to use anticoagulants very, very carefully in patients with the DICs because they will have both hemorrhage as well as thrombosis. So anticoagulants should be used at utmost precautions. Platelet therapy is indicated in patient who is having a very active bleeding, or patients who are requiring immediate and unavoidable invasive procedures, and patients who are at very high risk of bleeding complications. In these patients, you can think about platelet transfusion. Platelet therapy can be given for these patients. So DIC is not a disease per se. My friends, it is a manifestation of so many underlying disorders, especially the obstetric complications are very common especially in our setup. So they are the one which will manifest as a DIC. Once you remove these underlying disorders, DIC will disappear by itself. So it is very paradox. You will see both thrombosis as well as hemorrhage. So try to understand the concept of DIC as such. Thank you.